Happy Friday, everyone. My name is Ashley Johnson. Welcome to NAHU's Bridging HIV and SUD Innovations in the Field webinar series. Today's session is Evidence-Based Treatment for Stimulant Use Disorders Among Populations at Elevated Risk for HIV. We invite you to use the chat with to engage with your fellow attendees. To start, please add your name of your organization, your profession, and your city and state. Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of today's presentation. Today's session will be recorded. The presentation slides will be added to NAHU's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find this resource and to view past sessions. NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, AETCs, that support the AETC program mission. Established in 2010, NAHU supports the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations in order to promote and educate on the work of the AETC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and risk reduction of opioid use disorders and other substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see feature resources, check out upcoming ORN events and training, and learn about ORN work groups addressing health disparities and much more. A post-evaluation survey will be emailed to you after today's webinar and must be completed within 2 weeks to receive CME, CNE, Social Work CE, or a certificate of attendance. After 2 weeks, once the survey is closed, it will not be reopened. This link will also be added to the chat towards the end of the presentation. The minimum attendance requirement to receive CE is 60% of today's webinar. Participants who accrue less than 60% will not be eligible for CE. If you are a phone participant, please contact Liz Lazo to verify your phone number and to receive the evaluation link. Certificates will be emailed within 3 weeks of completing the evaluation. CE credits issued for participation may not apply towards license renewal in all states. Each participant is responsible for verifying the requirements of the state licensing boards. Today we have the pleasure of having Yona Tangi. Yona is Vice President of Medical Services and Gender Affirming Care at Amita Care, a nonprofit community health plan. Yona practices part-time as a telehealth clinician at Whitman Walker Health, a federally qualified health center in Washington, D.C., where they formerly served as the leader of medical substance use disorder programs. Yona is a member of the Contingency Management and Stimulants Power Team at the Addiction Technology Transfer Center, ATTC Network. Without further ado, I'll turn it over to Yona Tangi.
Thank you so much, and it's wonderful to be here with you all today. Please feel free as we go through to add questions to the chat or using the Q&A feature, and we'll get to those at the end. I also saw that some of you submitted questions electronically, so I've also copied those into the slides so we can see those at the end too. Okay. All right. Oh, sorry, I'm just switching windows. There we go. All of you can see the slide deck. Yes.
Yes.
Great.
It's not in presenter mode.
Is it there now?
There we go.
Wonderful. Okay, sorry. I have three screens, so sometimes I get lost between which one it wants to do on something that. But yeah, so it's wonderful to be here with you all today. And let's go ahead and get started. I have no financial disclosures, and we've already run through the different organizations that I'm involved with. I've seen that many of you put your names and where you work and professions in the chat. Seems like we have a really wonderful, diverse group in terms of profession, but also geographic area, which is great. And I'll try to make sure that we're covering things for both mental health professionals and then sort of the larger care team, as well as some stuff for clinical providers, because it looks like we have a pretty good mix of everyone. So we'll start. I wanted to make sure that this is kind of like a 201 talk, I would say, going further versus some of the other talks that I've done with NAHUD before. I also wanted to give some updates about some more recent studies and other things that have sort of come out since the last time I spoke for NAHUD, just so that you can kind of see that progression if you've been to one of these talks before. I still always like to start off with just some generalized context and level setting, just that way sort of everyone's on the same base, reviewing some basic epidemiology data, things like that. Then we'll go through the list of drugs that we're talking about in sexualized substance use. For this specific talk, I'm going to try and talk about stimulant use disorder a bit more broadly. But my focus area has always been on sexualized substance use, so there'll still certainly be a lot of information about that. Then we'll talk about how to translate guidelines and clinical research into therapeutic actions, including also behavioral health interventions, and then finish up with sort of like future needs in the stimulant use disorder assessment and treatment research space. Because I think there's a huge need for research in this space, and specifically research that is best designed to really help patients. And we'll talk more about that at the end to sort of close this out. This is looking at the relationship between stimulant use disorder broadly and HIV, and there's quite a strong association. So at the top here, you can see some information from HHS. They have found that when looking at a bunch of different studies, the prevalence of stimulant use disorder among people living with HIV has been estimated to be between 5 and 15%. So a pretty significant proportion, and depending on what kind of clinic you have and what kind of setting, that can be either more or less. In sexual health settings, it tends to be an even higher association. In general, when it comes to the stimulants between cocaine, crack cocaine, and methamphetamine, methamphetamine tends to be the most common substance, again, among gay and bisexual men having sex with men. And then cocaine and crack cocaine tends to have some differences or higher prevalences in people of color specifically, or people who have had a history of incarceration. At the bottom there, you'll also just see some excerpts from a study at an HIV clinic in California. And you can find that of their population who were using stimulants and then also living with HIV, they tended to be younger, white, living in economically disadvantaged neighborhoods, report sexualized activity that would put them at risk for HIV, like being gay, bisexual, or men who have sex with men. And then have some associations also with negative HIV care outcomes. So this is why it's definitely relevant and why we really want to treat it in the HIV care setting, because from both the prevention side and the treatment side, this is definitely something that can be a barrier for people. Although on the prevention side, there's actually a very interesting study. I'll show you in a couple more slides. That's, I think, actually reverses perhaps what some of us might have thought about PrEP and people who participate in sexualized drug use or use stimulants. I always like to make sure that we're being broad and covering all our bases. In general, if we're talking just about sexualized use of stimulants or just drugs in general, it's not that prevalent amongst heterosexual people. They tend to use more substances, like sort of by the prevalence data, like opioids, which don't necessarily have a sexual value. They have looked at it, though. There was a study in Britain specifically looking at heterosexual people, and they actually found that there is a slightly higher amount of sexualized drug use in people living with HIV, perhaps because of some community crossover. But in general, it's just a little bit of a different flavor, and the most common substances were cannabis and cocaine, so shorter acting things. Whereas when we're thinking about IV drug use in gay and bisexual men who have sex with men, the vast majority actually of intravenous drug use is meth and not opioids. Some studies have shown that over 90% of injection drug use in gay, bisexual men who have sex with men and transgender women is stimulants and not opioids. So I think that's another really key point. And if you are in a setting also where you're maybe partnering or working with a needle exchange, or maybe you work for a harm reduction organization or any kind of syringe exchange service, or other services for people who use drugs. One of the things that is a big issue for some people is that a lot of those services are really designed around opioids, around injection of opioids. And so in specific populations that have strong relationship with HIV, one of the issues is that they may not necessarily have spaces for them that do these kinds of services that were kind of made with them in mind. This is a meta-analysis of chemsex prevalence. This is an update. It was just published last year. The nice thing about meta-analyses is that because they include so much data, you can get more accurate conclusions. And what they did is they made both global and regional prevalence, basically numbers, for people who are participating in sexualized drug use by regions. Now, they found that Europe had the highest rates of sexualized drug use overall, and we know that certainly that Europe has a strong party drug culture. But North America actually had one of the highest prevalences of methamphetamine specifically, which we do know is of all the sort of party drugs, so to speak, is the one that we see more associated with negative sort of health outcomes and HIV outcomes. And so that definitely is relevant. This is looking at some of their tables, and I've just highlighted there with the red little bubbles, the North American ones. In North America, that does include also Canada as well. But in general, so you could actually maybe even consider, based off of what we know from other smaller studies, that the prevalence actually, if we're just talking about the US, might even be a little bit higher than these numbers. But you can see that depending on the substance, whether it be methamphetamine, cocaine, etc., we're typically talking about a range for most of these between 7 and 15%, with the overall prevalence being 15. But again, highlighting that the meth use actually was, North America was one of the highest users of methamphetamine. I always like to pull forward this slide to say also or to prove the relevance of sexualized drug use to the HIV care continuum. This was a study actually out of that was done in New York. And basically, the long story short is that they were looking at people who seroconverted. And what they found was that of the people who seroconverted for HIV, 1 out of 3 were people who were persistent users of meth. And what that meant in this study is that the study had 2 time points, 0 and 12 months later. If someone was reported using methamphetamine actively at both stages, then they were considered a persistent user of meth, and that was highly, highly associated with seroconversion. If you actually broadened that to just reporting either use at either point in the study, the association with HIV seroconversion was even stronger. So especially in certain communities, the association between sexualized drug use and HIV seroconversion is quite strong. Now, this was actually just published, and I added this in. I think this is really interesting, and it's also a systematic review. So again, pooling a bunch of studies to make hopefully more accurate conclusions. And what they were looking at is PrEP uptake amongst HIV negative gay bisexual men who have sex with men who participate in chemsex. Now, I think a lot of providers, when they think about methamphetamine use, they really just, or actually anyone across the care continuum, it's not just providers, the behavioral health providers, testers, etc. They think of it as a risk factor, and then also a risk factor for either negative care outcomes, medication not adherence, or just less healthcare utilization. And what was really interesting actually about this study is that they found that participating in sexualized drug use was actually associated with a higher odds of PrEP use. So there actually has been one other study that was a while ago, but that it was small, out of France, that showed that actually people who participate in chemsex may have a greater understanding of their own risk and might actually use PrEP at higher, at a higher rate. And this meta-analysis actually is kind of showing on a larger scale that that is somewhat true as well. What is interesting, and I think that the important thing is this is about someone who's taking PrEP. This doesn't tell us whether they're more likely to be taking PrEP. It doesn't tell us about how good their adherence is. And so that's the really key point there that I want to talk a little bit. We'll continue to talk about or bring back up is just because they're using the PrEP doesn't mean that they're using it well. And in this same study, they found that there was a stronger association with currently being on PrEP if someone reported sexualized drug use in some time in the past versus recent. Perhaps actually also like sort of speaking to someone who's in an active level of higher use may struggle with adherence. And in general, since they were looking at multiple countries, there were some different sort of like divides. And if you were interested in this paper, there's some interesting sort of breakups by population as well. So this is the little plot table showing that, and you can, so that red line is like the significance line, and if the dots are to the right of it, that means that it was a significant association. And just across the board here, you can see that things are skewing to the right side, showing that chemsex was associated with PrEP uptake. So I thought that was really interesting, especially because I think that some people, if like they get cynical, they may feel that it's not actually worthwhile to prescribe PrEP to people who use stimulants or anyone who uses drugs. Because remember, you can prescribe PrEP to also people who are injecting opioids or just have any sort of drug-related risk factor for HIV. But I think that this actually kind of like stands to show that it's not a waste of time to try with those folks, that they actually might be very willing to try something like this. And the biggest thing I think actually is thinking about how can we sort of optimize their PrEP to deal with the adherence issues. So before we kind of go and talk about some of the different interventions, and I'll briefly talk about PrEP again, like in that context, I just wanted to do some level setting around what is the diagnosis of a substance use disorder, and what are some of the different factors also that matter for like when we're talking about treating the whole person in the context of a stimulant use disorder. So these are the Healthy People 2030 CDC, like social determinants of health areas. And the reason why I'm showing this is that it's important to remember, because we're going to talk about both behavioral health interventions and medication interventions, that a huge part of a substance use disorder is nothing that we can fix in a clinic with a pill or with really good therapy or something like that. I think recognizing that also is really important to preventing burnout, because if you really hold the world on your shoulders, there's just really no other path forward but eventual burnout. But these are all the different areas of a person's life that really significantly just affect them generally, but also affect the relationship with a substance. And so having sort of like negative factors in each of these main areas is heavily associated with being more likely to develop a negative relationship with a substance, where it becomes essentially like a negative coping mechanism. When we define a substance use disorder, and I sometimes use addiction somewhat interchangeably, but this is really what we should be thinking about because it's the official behavioral health diagnosis. There are 11 discrete criteria as defined by the DSM, but if that's like sort of, it's a little bit busy, if you just want to think about it in the shorthand, you're looking for signs that someone has described that they're losing control over the substance. You're looking for signs that they may have cravings or urges, and that's something that they want to go away. You're looking for signs that they're experiencing social dysfunction. This is a really important part. Basically, in all behavioral health diagnosing or behavioral health disorders, we're always curious about how hard that makes the person, or how hard it makes it for the person to function. So are they experiencing social consequences, lost relationships, work problems, etc.? And then specifically when we're thinking about a relationship with a substance, are they developing some form of physical dependence? Now, the interesting thing about stimulants, but especially meth, which is longer acting, is that they certainly do sort of have like a withdrawal and a hangover, but there is not the same physical dependence as with like an opioid or with alcohol. Quitting it cold turkey will not do something negative to your body. And because if you were to continuously use stimulants all the time, you wouldn't sleep and you would eventually get like paranoid and psychotic. It's while some people can somewhat have like using as part of their need to feel normal, it's not necessarily the same thing in terms of a physical dependence as it is with like an opioid or with alcohol, where you also need to actually do a medical basically detox for safety reasons as well. So just applying that slide and social determinants to sort of the diagnosis of a substance use disorder. It is graded in the DSM depending on how many of those criteria you meet. And we know that, again, certainly therapy and certainly different interventions can help. But all of those things like untreated mental health, economic disadvantages, pain, etc., those can worsen someone's relationship with a substance if they lean on it more for coping But on the contrary, that one of the really important reasons in the SUD care to have an interdisciplinary team is that working with people on housing, making sure they have access to food or other resources, finding ways to integrate them into community and provide healthcare access in a way that's easy for them. These things help people sort of reassert control. The other reason why I like to show this as sort of like a waxing and waning spectrum is that I think that some people can have this idea that addiction is a discrete or chronic diagnosis. You get it and you have it for life. The truth of the matter is that there are many seasons to people's lives, and they may at one point in their life qualify as having a disordered relationship with a substance, and at one other point they may not. I think a really great example that's common for people is that there were a lot of people over the pandemic who perhaps developed like problematic drinking problems or other substance use. And once the pandemic sort of wrapped up, if they successfully like reintegrated more into community, they just sort of naturally progressed out of that. So it is actually common that people will sort of like move in and out of something, but sometimes, especially when it's more severe, I mean, especially also where the drug might have more like active consequences while you're using it, it can be harder for people to move back down the ladder. So I always like to include some more of the social theory. And this time, because I wanted to focus on other things, I just put this slide up for reference, sort of as like a journal club. So if you're interested more in sort of like the social theory ideas or just sort of like learning about like the cultural context of sexualized drug use, these are some interesting papers that you can find out there. I think I have PDFs of all of them, which is wonderful. So if you wanted a PDF, you could always email me and I'm happy to send out those resources after if you're interested in learning more about these. I think what I like about these ones that are up here is that I think they are very interesting writings that really make one interrogate their concept of what drug use is and what it is not, etc. This is not necessarily me also endorsing that any of these is like absolute fact and like the way you should think about things. But I think that these are all really great papers to sort of like expand your thinking. And in that expansion, you might find useful things for clinical care. Okay. So now would be a good time to type in any questions if you have them into the Q&A from this first section, if there's anything there. Now we're going to move into talking specifically about some substances and a little bit of the pharmacology too. So bear with me if you're not a science person. I'm going to try to do my best also to make sure that this is understandable to everyone. But I really do believe actually that understanding a little bit more about how the drugs actually work for people helps in terms of being able to care for these people and sort of like know what's going on. And, you know, I do some of this education on the pharmacology of like substances also with patients, because I think that the more people understand both why they're using, how they're using, and what they're using, the more that they may have an ability to sort of reassert some control over that and think critically about like what needs to happen in terms of their substance use in terms of reaching certain life goals. So this is the drugs wheel. I did not make this, giving credit where credit's due. You can find it at thedrugswheel.com. What I like about it is it shows all the different sort of categories of substances. And then on that outer ring, like this, which is like sort of the first one in, that has the common substances, what are people like what people commonly think that they're using. And some of these tend to be skew more towards the ones that are somewhat naturally occurring, although there's some synthetic ones there as well. On that inner ring where you see some very like convoluted sort of medical words or abbreviations, those are the designer and synthetic drugs that oftentimes actually are more of what people are using nowadays because of the polluted drug supply. So if we're thinking about stimulant use disorder in populations at elevated risk for HIV, especially like in a sexualized context, we're thinking, or actually even in the non-sexualized context, in terms of stimulants, we're thinking about cocaine and amphetamines. Ephedrone is like this synthetic meth. That's the easiest way to think about it. So that's why that's highlighted there. Sometimes there could be some party drugs in there too, like ecstasy. And then among some of those other ones, in terms of the ones that have like sexual relevance, we'll talk a little bit more about G and the pharmacology of that because I think it's not well known. Ketamine can also be used in sexualized drug use, but doesn't tend to have the same sort of like long-term health consequences. Although people can develop a ketamine use disorder, it's just less common. And that weird benzodiazepine, a benzo is something like Xanax, if you've heard of that before, or Ativan or Valium. Flunitrazepam is a strange benzo that is oftentimes actually one of the pollutants in what people think they're consuming as G. That supply, especially in the post-pandemic world, has remained heavily polluted. And actually in DC, I want to say 2 or 3 years ago, we actually did have 2 overdose deaths related to fentanyl-laced G. I usually don't like to give too much, I don't like to sensationalize fentanyl more because there's a lot of sensationalism about it. And for the longest time too, we weren't really necessarily seeing fentanyl being polluted into the stimulants. Because generally it doesn't really make sense to put an opioid in an upper that's not going to give people what they want. We have seen a little bit more pollution in the stimulants, so I would say it is something that happens. But where I really worry about fentanyl, basically diluent, is in those depressants, because again, it's going to be the same effect, and so that's why it is something of concern, especially with a depressant like G. So these are the sort of like looking at all the different categories. This is just talking a little bit about what it actually does to the body. So I'm not going to go through these one by one or read all of them. They're there for your reference in the slide deck. But again, the ones that are going to be most related to sexualized drug use are going to be those depressants, because they cause the inhibition, the relaxation, and they allow which is helpful. And then the stimulants, which cause an increase in sensation, as well as the empathogens, which increase sexual arousal. And this is again just another way of looking at that, mostly looking at that would be relevant to the sexual context. I will say we really don't see too much of like psychedelics used in the sexual context, or opioids, like we said, or like I said earlier, or and then I would say the cannabis thing is something that definitely follows the line, sort of like sexualities, with cannabis being way more common in heterosexual communities in terms of a sexualized substance. The next little bit, I just wanted to include this brief little PSA. This is just a standard tap screen here that's been modified to include some questions about sexualized drug use. I'm a big proponent of including specific questions for sexualized drug use into standard clinic flows at workplaces when you're doing any kind of a social history, if it's relevant also to the kind of social history you're taking. I really think when you ask about it separately, you'll oftentimes actually get an answer that is different than if you just asked about substances generally. And we can actually see that this is an adapted TAPS that was at the workplace, my workplace, Whitman Walker. And what we found actually is a good amount of the time, people say that they don't use crack, cocaine, meth, or ecstasy. But then when you ask them with a sort of also street lingo, do they do that in the context of during sex? A decent amount will say yes. And so the other reason why I've sort of shown this is that I think it's really important to have that separate question. And what's interesting is that a lot of times people actually might respond to having a separate question versus not respond to a general one, because they feel more comfortable with the language, or perhaps because they feel like knowing that the clinic or the space understands what sexualized drug use is allows them to open up. The other thing I actually think that's also very useful about this is that even in heterosexual communities, the amount of people taking sildenafil or tadalafil, which is Viagra and Cialis, from online pharmacies that never report it to their providers, is actually pretty high. And it's oftentimes something that people don't think to mention. And there are some important interactions with those drugs and other drugs, especially blood pressure medicines and things like that. So it actually even also in heterosexual folks is a great way to find out about perhaps some usage of online pharmacy medications. So moving from there, just updating. Okay. Just some things about general safety counseling, and then we'll get into PrEP again, and then talk more about harm reduction exercises that are more specific. So these are just some general ideas, and this is definitely something that anyone on the healthcare team can talk with people about this. Whether you're a frontline test person, whether you're a peer, whether you're working in behavioral health, or in direct clinical care. These are just some really like sort of broad area, areas that you can think about in terms of starting a conversation with a patient. And again, before you also ever have a patient like interaction where you might like give them some information, it's important to ask them first if they want to have that conversation. That was actually written into this reader on the other slide. It asked people if they would consent to talk about their substance use. It's really important, especially for people who use substances or living with HIV, who oftentimes there's so much stigma wrapped up in both of those things. They have a lot of sort of like fear around accessing healthcare. It's really important to give them as much autonomy as possible. And it also just sort of helps you also as a person giving the information is that if a person has not consented to receive information, their learning from it oftentimes is not going to be very high because they're just sort of listening. But if that person like says yes, it really kind of opens the door for engagement with the information. And so that way, maybe they actually might take away some information that could help them with their safety. So talking about it like non-judgmentally with interest, that's what it's sort of like, I think a foundational thing for talking to people about substance use. Especially with stimulants across the board, definitely a concern about hydration and nutrition. Both cocaine as well as methamphetamine can have significant effects on the kidneys. They're both also appetite suppressants, especially methamphetamine, which hangs around the body much longer. And so also if someone was living with HIV, they have additional risk factors for wasting and other things like that. So nutrition and hydration are just really basic things, but still actually important to highlight. Because you might think, oh, everyone knows to eat and drink, but for some people, they might need to hear that extra reinforcement saying, based off of some of the things that you do, you really need to think actively and proactively about your hydration and nutrition. And specifically as well, I find that some of the nutritional supplements, if you're able to offer them in whatever kind of clinical or like subclinical setting you have, are really, really helpful for this population. Things like Ensure or Boost, because since their appetite is suppressed, it is often hard for them to eat a meal. So a sort of like nutrient-rich shake like that, like an Ensure or a Boost, could be a great intervention for those people to be able to get like some calories and decent nutrition. One of the really cool programs I was happy to work with while I was at Whitman Walker is we installed harm reduction vending machines. And we had specific supplies in ours for people who injected stimulants versus opioids, but also some basic like hydration and nutrition, water and like Ensure and things like that. And especially Ensure and Boost because it is more expensive. If there are ways at your clinical sites or whatever sort of like healthcare space that you are in to offer those or find ways to offer those at like little to no cost, it's a really great intervention for people. Other general like sort of areas to talk about are situational safety and accountability. Especially accountability when we're thinking about people moving up and down sort of that like disordered relationship with a substance, being honest with their friends and family members about their use, especially if you have someone who like really does not think of their use as a problem, is just interested in harm reduction, but does clearly have a more significantly disordered relationship with a substance than they're sort of like able to get there. Motivational interviewing is great, but then also talking about accountability and being like, you're saying that you're very in control. Why don't you set some goals? Are you accountable with those goals? Are you telling other people too? So how do they view your relationship with the substance? The more you can kind of bring in community, the better. And situational safety, when we're talking about like drug use in any context, but especially like sort of like sexual context, obviously there's always a risk there. I'm talking about buddy systems and making sure that people have people around them that they can trust. I'll go a little bit more into the STI prevention. Of course, we want everyone participating in something like this to be undetectable if they're HIV positive or on PrEP if they are not. DoxyPEP is also an extraordinarily great intervention for this population because they are at higher risk for STIs like gonorrhea, chlamydia, and syphilis. And then just talking to them about where they get their supplies. In some states, there are even really cool harm reduction, sort of like mail order harm reduction ones that can mail people syringes, but most places have some kind of local syringe exchange program. And so this can be a great time to sort of bring that up with people and about talking to them about using safe supplies, making sure they're not reusing supplies and helping them to find those places where they can access those resources. So since we have people who are both like clinical providers and then sort of in the behavioral health space, I wanted to briefly just show this little PrEP algorithm, which kind of follows along with the updated CDC guidelines, which is basically to offer PrEP to anyone who is sexually active. Although we'd also expand that too to someone who is at risk for HIV through drug use, whether that be like injection drug use, etc. Now, there are different options depending on whether someone is assigned female at birth or male at birth. These are the various different options. The thing I wanted to bring forward from that study about how people who were participating in sexualized drug use were more likely to be on PrEP does not talk about how well they are adherent to it. And we do know that in general, people, especially if they have a more chaotic substance use disorder, are going to struggle with taking a once daily pill. And while you only need actually for either of the oral pill options to take the pill at least like up to 4 or 5 times a week, it's a little bit more forgiving than some other pills in order for it to work. That can still be very hard for people, especially if their sense of time is altered, as it often is for people using stimulants. So I would really advocate for use of injectables in this population wherever possible. Like I said, they are interested. This population is interested in PrEP, so they should not be written off as like not going to be able to do it. But especially now that we have a 6-month option, I think that's a really great concept for people who have this increased risk. And so I would say, like, especially if you have someone that's reporting sexualized drug use, I would think a lot about the long-acting injectable options, especially for them, because their concept of time might be different. They may struggle more with adherence. They're at higher risk. And especially also if they have risk from both like injection drug use practices and like as well as sex, you're definitely going to want to try and get like the best option for that person. This is a little bit about DoxyPEP. The CDC also has their little guideline about it. I just wanted to put it as sort of like an informational resource in the slide. But basically, it's just a way of taking a little dose of an antibiotic after sex to reduce your risk of gonorrhea, chlamydia, or syphilis by about 2/3. Again, for people who are in these populations, this is something that can be offered in tandem. And I think there's really great uptake at this because people are excited about it. STIs like don't always cause symptoms, but for those that do, people really hate it when they experience those symptoms. And so if someone's ever had a symptomatic STI, they oftentimes are very motivated to prevent that from happening again. And this is going to be a great way to help them. And also lower significantly sort of the community spread of those different things. The other thing I'll say about this, because I think people specifically with DoxyPEP are always a little bit nervous about antibiotic resistance. It's important to remember that people take doxycycline literally every day, all the time for acne. And it's been like they will use that for years. And so actually versus the other antibiotics, there is more data on sort of long-term usage of doxycycline than other antibiotics because it does have that indication for acne for people taking it regularly, even if it's a smaller dose. All right, to kind of wrap up this section before we go into sort of like the pharmacology section, this is just a little bit about specific harm reduction exercises, especially if you're a caseworker or behavioral health provider or someone who can spend a little bit more time with the patient and you're sort of interested in this is within your scope to do it. These are a couple of different resources and then also things you can talk about people with. One little resource to start off that I really love to highlight is something called Never Use Alone. If you've never heard of that before, basically, well, let me actually start off like or back up for a second. One of the things that actually for me as a provider worries me most is when someone goes from using a substance in social contexts at parties or with a small group of friends or in a sexualized context to using by themselves, because that tends to be a sign of like sort of the disordered relationship progressing, because now they're just using it for the sake entirely of the use and they're isolating as well. So Never Use Alone, which can definitely also be highly recommended to people who use opioids, is basically just a warm line where either through a website or just through dialing a phone number, someone can have like a human on the line. So that way they are not necessarily like if some kind of medical emergency happens while they're using, there's someone who can call emergency services. So that's a really great resource for those kinds of people who, again, have one of the more chaotic relationships with the substance. But, also just talking to people again about the accountability and having people they can trust around them, that's still relevant as well. The other thing in terms of what I meant earlier when I said I'm talking to people about treating their substance use like a science is there are little interventions you can do like this, like setting limits and measuring things that can be ways for people to start to be, again, more accountable, but also sort of track how their substance use is sort of like affecting their life. And then that's a great way for them to sort of showcase, is this actually playing the part in my life that I thought it was? Or is it a little bit like, or is it actually having more negative effects? Or is it fine the way it is for what their goals are? Something that can be a useful thing to talk about people is something called a drug holiday, especially if they've been having some problems. So if they're concerned that they're using more and more often than they used to, planning some kind of like time period where they're not going to use as a way to reassert control and reduce tolerance. I often find when talking with patients, it's great to connect these to some kind of life event. Like maybe they have a birthday coming up, or they're planning on running like a 5K or some other family events or something like that. It can be a great way to sort of connect that to it to help them meet their goals. I think that covers most of the things here, so I'll move on. All right. So I'm not going to be super in depth with all the sort of sciencey parts, but I want to sort of just take some time to describe the differences or like the nuances of like meth and cocaine. We'll also talk about G because I think a lot of people, as I've always sort of taught, or as I've talked about it in different lectures in different settings, it's one of the substances that people are less familiar with. And so I want to spend a little bit extra time, or there'll be more than one slide on that one, just because I think it's something that people know less about. So methamphetamine is similar to sort of the little like things that are neurotransmitters in your brain, chemicals or however you want to call it. You can look all the different shapes that are around you. You don't need to know about a benzene ring or about organic chemistry, but you can just kind of actually see that if you look at methamphetamine versus some of these other molecules, it looks kind of similar. And that's why it is able to cross into the brain from the blood because it is like so similar to those other neurotransmitters. Compared to cocaine, meth lasts a lot longer in the body and also does not have as like quick or as steep of a high. So whereas like you can think about cocaine more of like a peaked mountain, meth is more like a rolling hill. Which is also why for some of those negative effects or like long-term like staying up or things like that, that can be more of an issue. It also tends to be more bad for brain health than cocaine. And part of that is because something that is unique to methamphetamine is that it floods the brain with dopamine when it is taken. And so that big dopamine flood, I move on to cocaine. I don't have that other slide on that. But that big dopamine flood is something that's sort of unique to meth. And that also is thought to be part of the reason why it has some associations with negative brain health long term. And that goes for other medications also that cause that. So amphetamine type stimulants like your prescribed Adderall, Adderall XR, etc., things like that are also not great for brain health long term. There is somewhat of a dose effect on this. So usually an oral stimulant dose for an attention disorder is going to be a lot safer and less likely to cause long-term brain health problems, but it does work the same way. And so it's important to think about in terms of the class difference between these things. And like I said, it both floods the brain with dopamine and then has those neurotransmitters sort of last around longer. So it works in two different ways. Cocaine, on the other hand, doesn't flood the brain with dopamine. It just kind of makes those neurotransmitters hang around longer. So it doesn't have that big dopamine rush the same way that meth does. Similar to meth, it does cause vasoconstriction, and actually it is still used clinically in surgery, especially ENT surgery for this reason. The other thing that you want to think about as well, both meth and cocaine can have negative effects on the heart. We worry more about acute heart problems in people who are using cocaine or crack cocaine, just because it can be a little bit worse for the heart for some, even though they both raise blood pressure and cause some other things related to heart. It can be a little bit more worrisome, specifically with cocaine use, because it also increases also just the demand on the heart. But again, both are going to put the heart on, are going to increase stress on the heart. Unfortunately, also cocaine has an association with blood clots as well, which can sort of like also add into sort of like the heart health issue related to cocaine use. So GHB is a naturally occurring brain chemical. There are specific receptors for it in the brain, and when you use it, or when people use it, it's sort of like it has like both depressant effects, but then also like dopamine happy effects. And people often describe it as like a happy drunk, or that's how I like to think of it. But basically, because it has those multiple different sort of effects, it's not just like an intoxication of alcohol where it makes people sort of reduced senses and things like that. It also increases libido and causes like a sense of like warmth and euphoria. And that is why it has sexualized usage. I will also say that GHB is also like one of the very common like date rape drugs. When you hear about people like something being slipped into someone's drink, if it was a liquid, it's often this. And the reason being is actually that GHB works on the same, or like has similar crossover receptors with alcohol, like the GABA receptors. And so when you combine it, it's like doubling amount of the alcohol intake. So the likelihood that you're going to pass out or like be sedated is much higher. So I think this covers most of what I just said, but so I won't repeat it. One of the interesting things though is just like, so I said that GHB works on the same receptors as alcohol or similar receptors as alcohol, which is relevant because again, it can be used as a date rape drug. But also like alcohol though versus stimulant, which is a difference from stimulants, is you can form a physical dependence on GHB where you would need to undergo a detox to safely come off of it. And because similar to alcohol, if someone develops a true physical dependence, if you quit cold turkey, you can have seizures or other serious health consequences. Interestingly, I mean, there's that old adage that the difference between a drug and a poison is the dose, but in this case, it's also sometimes the indication. GHB is actually still prescribable as a sort of a sleep aid, but it's very uncommonly used because it's only for people with narcolepsy. It is actually used in other countries both as an anesthetic and as a treatment for withdrawal. So just to add a little bit more about the context of what GHB is. Now, the reason why I have these different forms on here, GHB, I believe, was scheduled in like right at 2000 or like a little, like give or take a year or two, like from that area. Oh yeah, it's scheduled at 2000. That's right there on the slide. Yeah, so it was scheduled in 2000, and since then, it's really not like something we see a lot. What people think they are taking, which is GHB, is oftentimes these other two molecules that are on the slide. GBL, which is a precursor and is about like twice as strong as GHB, or 1,4-BD, which is the most common thing we see now because it's somewhat commercially available. You could technically buy it on Amazon to this day, I believe, because it's sold as an industrial chemical. And the reason why it's relevant to talk to you about how there's different forms of what people are actually consuming is because it really affects how it hits the body. So GHB, which is that sort of, can you see my cursor? I'm not sure if you can see my cursor, but so GHB, which is the one sort of like towards the bottom there, that's circled in red. That's the one that's going to sort of have the direct effects that we talked about in terms of the effects that people are looking for. Now, GBL, which is the one that's directly above GHB, is a molecule that basically like just gets converted almost into gets converted into GHB in the blood. So it's rapidly converted because if you take it, it goes like when you eat anything or consume something, it goes into your bloodstream. It gets rapidly converted, and so it is stronger than GHB and has a very similar effect. And that conversion tends to be very fast for most people. Now, 1,4-BD, which I said is actually what most people are consuming, but they usually don't know it's what they're consuming, that gets converted into the active molecule GHB in the liver. And so it takes a little bit more time for it to reach the liver. There's also two different enzymes that do that conversion. And again, you don't need to know the chemistry or the other things about that, but every enzyme in our body is genetically coded, and there can be differences between people based on their genetics. Because there are more steps in the process for this specific chemical to be turned into the active one, it can take more or less time based on someone's genetics for this molecule to have the desired effect. And the reason why that is relevant is that one thing we specifically worry about with people who are even intentionally using G, not in a date rape context, is that they overdose it, which could lead to respiratory depression or even death, or just loss of consciousness, which is also not great or safe for people. And that's specifically more of a problem now that 1,4-BD is the most common chemical because it is more unpredictable about when it will hit people. And so the problem is if someone is using this in a communal context, one person might feel the effects of the drug in like 10 minutes. It might take like 30 minutes or more for someone else. And if they don't wait, they might try and take like another dose and then accidentally put themselves at risk of an overdose, which is a big concern. So I hope that helps like understand more about G and some of the things with it. And I would say that there's a huge amount of misunderstanding even within community about what they're actually taking and what they're actually doing. Most people usually just say G and they mean any one of these. And if you actually analyze what people are taking, it oftentimes is a mix of these chemicals and then also other sort of other adulterants. Now would be a good time because we're going to move on to two more slides, sort of about the pharmacology of things. To type in a question if you still have a question about that. So I decided to make a separate slide on synthetic cathinones, which is kind of like that category that includes like the designer stimulants I was talking about before, like mephedrone, which you can kind of think of as like synthetic meth. These molecules, depending on which one or which drug that you see there's a list of common ones below. They can have effects that make them similar to ecstasy, cocaine, meth, or sometimes a combination of the different drug actions like those. Mephedrone is one of the more common ones because it's more sort of similar to meth. Well, I shouldn't say similar to meth, but the effects are somewhat like overlapping with meth. What's interesting actually is that bupropion is actually in this category or this family of molecules. And bupropion is a prescribable antidepressant. It actually can be used and has been shown, and I'll talk more about that later, to be helpful for people with methamphetamine use disorder. It actually also helps people with attention disorders as well, even though it's not labeled for that indication. And that's because you can really think of some of these as like cousins of typical stimulants that are synthetic versions that have sort of unique effects. So it's also in that category. So they're not necessarily like, well, again, the difference between a drug and a poison is the dosage and then also sometimes the indication and sort of the relevance there. Now, nowadays, when people are using various stimulants, oftentimes they are polluted with these different sort of synthetic molecules. I will say you do worry about adulterants more in something like cocaine, just because it is more expensive and harder to make, because it requires growing something. Because meth can kind of be made on smaller scales as well, you tend to see there still certainly are adulterants in them, but it's just sort of like a little bit different than some of the other like drugs out there. And the other thing, so some of these, though, are actually quite negative for the body. If you remember when people used to talk about bath salts or like Florida person on bath salts because of just like sort of like the standard sort of Florida person story, some of them, just like any stimulant, but some of these are more prone to cause things like psychosis or other things like that. And if someone uses a stimulant and doesn't sleep for more than like 3 or 4 days, they will start to develop paranoia and psychosis. They've actually done a study before where I think they just used caffeine pills, and they found that like by day 3 of keeping any person awake, they start to display like the formal signs of psychosis. So just sleep deprivation by itself, also in combination with some of the effects of these different these different substances, can predispose people to developing that. So this is actually this is data from DC sort of like syringe surveillance. Many states and many localities will have this, especially if you live in a more urban area. It's sort of like in the forensic lab or whatever your local forensic lab is. Not everyone is going to be able to access this kind of data, but I think it is relevant if you're working in the HIV prevention and treatment space, but especially also if you're working in a space that overlaps with drug treatment, to sort of find out a little bit more about the area you're in. Because what are the most common adulterants is really regionally dependent. So, for example, like when we first were starting to see fentanyl, that like sort of happened first in certain cities along certain corridors. And xylazine, yeah. And when we started to see like xylazine, for example, which is that chemical that started to pollute opioids that caused all those crazy wounds, we saw that happening like more so in Pennsylvania, for example. So the different adulterants end up in different places, and so it's always going to be like about your regional context. So I'm showing you this data from DC, and that's showing you that I'm looking at stimulants on a cocaine syringe, that there are a couple of those synthetic cathinones on there, which are those synthetic stimulants. I wanted to highlight that. But I also wanted to use this as an example of something you could try and seek out, which is your local forensic data. Some places, like I said, will have a forensic lab. Others you might have to do more digging, but I do think it's actually really useful to know, especially in the drug treatment space, because it helps you like better care for patients, helps you speak with patients more about what might actually be in the substances that they're consuming. Yeah. And this is just looking specifically again at what synthetic cathinones are in the DC area based on syringe surveillance data. And again, that's just going to differ between different regions, just sort of based on how like the drug supply works. But I definitely think it's interesting to know. And I think that people need to be talked more about these molecules. Some of them are actually even starting to enter the party drug space. I've heard more about people consuming 4-MMMC and other things like that, or 3MC, I think is there another one that's sort of similar. So I think that the other reason why I wanted to sort of put this on people's radar today is I think that these substances will become more and more clinically relevant for us. And of course, because these are substances that usually are not what we're considering like the primary substance of a primary substance use disorder, they may complicate treatment because of what we don't know about them, and we don't really have any data on how to directly treat something like this. All right. So we're making good time. The next section we'll talk about sort of therapeutic actions, and then the ending is just sort of some stuff about future directions for research. So that will be pretty quick, and I think we want to leave at least 15 minutes for questions, and so I think we should be able to get through that. So one of the things about when we're starting to think about actually moving in towards like therapeutic actions to help someone with a disordered relationship with a substance is that oftentimes there's this question of like the chicken or the egg question of, do they have a mental health problem that they're self-treating with substances? Or is the substance use kind of like causing their mental health problems? The other thing I will say is that especially with people who are using any stimulants, cocaine, crack, or meth, I see a lot of false diagnoses of bipolar disorder. And the reason there is actually like pretty straightforward is that meth high certainly sort of like someone being high in a stimulant sort of is similar to someone having mania. And they're going to go through cycles of sort of a depression and then a high based off of their stimulant use. Technically speaking, if someone is in an active substance use disorder, you're not really able to formally make that diagnosis. And it is relevant for treatment because if you think that basically, if you diagnose this or misdiagnose this, then use some of the treatments for bipolar disorder, they may either not be effective or potentially even be harmful for the patient, depending on sort of what route that you are going on. So I really want to say with this slide is that whenever you are working with someone with a stimulant use disorder, it is incredibly common for them to also have mental health disorders. And many of those could be the driver of the substance use. They may not be the driver. That's something that you can try and sort of like work towards discovering with the patient as well, like in tandem with the patient. But whenever you come with like or meet someone new, if they come with a list of a ton of mental health disorders, but then also a substance use disorder, it's always worth sort of thinking critically and not just taking those different mental health diagnoses as fact, because sometimes they just get added in there. They show up at an emergency department because they haven't slept for 2 days, and so they just get like bipolar diagnosis thrown in there, or a psychotic disorder like schizophrenia thrown in there because they were psychotic after using or stimulants for too long and not sleeping for too long. This is just the like different ASAM levels of care. So the first thing to think about whenever you're trying to like when we're talking about moving from like understanding the substance use disorder to trying to do something about it is what is the appropriate level of care for someone. If someone has a truly very severe disorder, they're going to need a higher level of care like a residential program or maybe like an IOP or PHP. Whereas someone, if it's more mild to moderate or they're just trying to make changes, then outpatient is acceptable. But it's important to sort of think about that at the start, because again, if it's very severe and you think that it's really going to take residential to sort of break the cycle, starting to introduce that concept to people as soon as possible is always good, because usually people are not immediately ready to go into some sort of like inpatient treatment process. What was really wonderful is that in 2024, ASAM, which is the American Society of Addiction Medicine, released new guidelines about the treatment of stimulant use disorder, both cocaine and amphetamines, or amphetamine type stimulants, which includes meth. ATS just stands for amphetamine type stimulants. You can see it down there. For a long time, ASAM did not recognize any treatments for stimulant use disorder, and they did not recognize the medications. Even though there is decent evidence for some of these medications, none of them are labeled for the treatment of stimulant use disorder. But as I'll talk about later, that actually has to do also partly with the reason and the why of how things get labeled in this country for different indications. But they sort of about faced with these wonderful 2024 guidelines, and they did a thorough review, and they've shown here both options for medication treatment as well as sort of behavioral treatment. So contingency management is really the standard of care for stimulant use disorder, whether it's meth or cocaine, doesn't matter. And I'll go into more depth on what that actually is. There's a few different kinds of therapy that have been shown to be helpful specifically for stimulant use disorder, like CRA, CBT, and the matrix model. And then in tandem with these things, you can consider prescribing different medications. And there's actually a couple other ones on there that I'll also bring up that have some evidence. Now, there is actually a difference between some of the drugs that might be helpful for cocaine versus amphetamine. And remember, as we talked about earlier with that pharmacology part, there's a difference just the ways that the amphetamines work in the body versus cocaine. And so that also is like something in terms of the difference of treatment. I'll highlight more of these on the slide for the pharma part. So behavioral treatments for stimulant use disorder, like I said, contingency management is really the standard of care, but community reinforcement approach, CBT, matrix model, and motivational interviewing can also be helpful. So if you haven't heard of contingency management, it basically uses the psychological principle of conditioning to and like the brain's natural reward pathways to reinforce a positive behavior. So specifically, what that means doing is using either a voucher or a cash prize upon verified abstinence, meaning equating that with positive behavioral change, the negative drug test, with a reward. And that's it's the psychological principle of conditioning. And because you're doing a reward immediately after the changed behavior, in this case, showing that you were not used stimulants, it sort of activates that reward pathway and sort of really engages people. Depending on what it's been very well studied. CM can be something that happens for weeks or even months. What I also want to highlight is that California actually, as a state, has a statewide Medicaid CM program. So they have thousands of people doing this. And I really think that is the model that we should be trying to bring to all states. So part of the reason why I'm focusing on this today is sort of a call to action to try and start more CM programs, because it is a gold standard intervention that really helps people. And it is possible to sort of build larger programs. Besides the California Medicaid program, which is one of the largest ones, it's thousands of patients, multiple sites. The VA, the Veterans Health Association, has long been doing CM through a voucher-based protocol. And they actually also have been a great source of some of the different studies that have shown that it is a useful intervention. So the one thing about contingency management that as a harm reductionist is always sort of a hard pill to swallow is that it is always abstinence-based, just based on how it is. It is not like the conditioning and the positive behavior change can't really happen from a harm reductive model, just specifically the way that this is sort of set up. I certainly think that you can have other sort of incentive programs that could be helpful to people using substances, but specifically for this, it is more of an abstinence-based protocol, so it would only be appropriate for people seeking abstinence. The abstinence end goal, though, to me, again, is not the most important thing. It's more about some of those other metrics. And it has been shown that contingency management reduces mortality. It produces a durable response. So a lot of people might worry, oh, they're getting the rewards for being stimulant-free. As soon as the rewards go away, they will know, they'll start using stimulants again. And that's actually been found to not necessarily be true. There's a pretty good durable response of up to a year later. And I can send these papers if anyone's interested. The most common protocols are more in the 3 to 6 month range because the few week protocols tend to be too short. And you can see there actually the exact incentive schedule from the California Medicaid program, CM program, which is a 6 month program. And the reason why it comes out to $5.99 is just the tax implications if you pay someone over $600, there has to be like a tax form. And so they did not want their enrollees having to deal with that process. So if you want to learn more about it too, when they published those new guidelines in 2024, they also published their evidence to decision tables showing what studies they evaluated, how they rated the quality of those studies, and how they drew their conclusions. The primary outcome in most of the research about CM is whether or not people achieved abstinence, and it's very effective at helping people achieve abstinence. And like I said, there is some good data on the durability of treatment and reduced mortality. We do want to see more of that data, though, because I think for a lot of us, we're really trying to treat the disordered relationship with the substance. And sure, stopping use of that substance, especially if it was a severely bad relationship with the substance, is a great end goal if that's what the patient wants. But there are many people that don't necessarily need to achieve total abstinence to do better with their health. So it would also be always great to see some more data like going forward about some of those other things like HIV outcomes and mental health outcomes for people who are enrolled in contingency management. But again, this is the gold standard treatment. So I don't want people to think of it as like experimental. This really is not an experimental treatment. It's something that's been around for a while and it's well researched. The biggest barrier why some people may not have heard of it is just that there aren't as many programs as there needs to be, just because of the logistics of setting one up and who's going to fund the incentives, et cetera. So the other thing I actually want to or one actually more point I want to make there is thinking about how you can sort of start this where you are. There used to be a lot more government funding for this, but I really think you now have to think about the state levels. So like I said, California Medicaid has a program. I think most states through their Medicaid programs or their managed care organizations can make these kinds of programs. Insurance companies would be the most obvious funder of someone who would see who actually would benefit from someone being in contingency management. Because since we know that having an active stimulant use disorder is going to put someone at risk of hospitalizations, of health consequences, and therefore costing more money because they utilize more healthcare at the emergency level, that's the most expensive hospital level, that's the most expensive level. There is actually something to their cost benefit analysis of offering a treatment that costs money to people, just like any treatment that costs money. If it works, then we know that it does work. So if you want to start this and your local area does not really have any grant options, or you can't find someone to work with you on it, actually thinking outside the box at payers might be an interesting way to do this with your local managed care organizations, if you have MCOs through your Medicaid programs or other sorts of payers. Yeah, but I think it's something also where I think we need it in more diverse settings too. Certainly this is something that can be housed within a drug treatment program, but I think integrating this with primary care would also be very wonderful. And we can talk more about that if people have questions at the end. So I'm going to go through just some things about the meds, and then I think we'll probably wrap up there, and I'll just mention one or two more things about research. So again, you'll have this as reference. I'm not going to go through this extensively, and I actually think the video is still there for one of my first talks I did with Nahud that kind of goes through these with more detail. But these are some of the various medications that have shown to have some benefits for people specifically using meth. There are also other, I have not actually put up the slides for cocaine, but I think actually the ASAM guideline does a great job of that. So you can just look at that algorithm in terms of seeing what meds are more paired with cocaine. There is some overlap. Two things I do want to quickly highlight off this one. There's only one medication that has been specifically studied in gay, bisexual men who have sex with men and transgender women who are using stimulants in the sexualized context, and that's mirtazapine. And in those two studies, they showed that even with people with crappy adherence, meaning they weren't taking it every day, it still actually was helpful. It reduced some of those secondary outcomes that we care about, like anxiety, depression, and gave them more sleep and appetite. But it actually showed that also they did decrease their use a little bit with it. You can really think of mirtazapine as the exact opposite of meth. It makes people less anxious, less depressed, sleepy, and hungry. So that's why it has been studied also in sort of meth detox or meth withdrawal treatment protocols. It was on the large scales not necessarily found helpful in some of those studies, but in this specific context, it was found to be helpful. And again, I think that it's important with any of these medications to have realistic expectations about what it does. It's always important to talk to people. If there was a silver bullet medication that could solve your relationship with this substance, you'd already be on it and everyone would know about it. All we can do is offer you some things that might help you reassert control or deal with some of the negative side effects that you're dealing with from your substance use. But like if your eventual goal is abstinence or less use, you also may need a little bit more than that. So just sort of expectation setting that there is no silver bullet out there, but that these medications could potentially help with different sort of parts of your active substance use. Highlight there about long-acting stimulants for methamphetamine use disorder. In that ASIM algorithm, they embrace methylphenidate formulations for methamphetamine use disorder. And there's also an embracement also of actually using a long-acting stimulant for cocaine use disorder. The idea here is the same idea as using methadone for opioids. If we're thinking about basically just satisfying that appetite that someone develops with long-term use for needing a stimulant to feel normal during the day, and then you can reestablish the sleep-wake cycle, this is a way of giving that to them without them needing to take street substances. It, of course, will always be safer for someone to use a prescribed stimulant than street meth. So I think that that is there's a huge stigma barrier to providers being able to prescribe this, but it really is the best thing for the patient. There's good data on it. And there's just no way it isn't safer than them continuing to use street stimulants. I will say one thing that was not really mentioned in the ASAM guidelines, there was a really large trial out of Sweden that showed that lisdexamfetamine, which is definitely not a methylphenidate formulation, was really great, or that like reduced mortality for people living with a stimulant use disorder, or specifically methamphetamine use disorder. But I'll show you actually on this next slide the reasons why ASAM chose methylphenidate formulations. So I talked about earlier how those amphetamine type stimulants have some potential to do bad things for brain health. They also just have when we're talking about attention disorders, they're actually more effective, but they're worse for you long term. Methylphenidate is another stimulant. It's an oral stimulant, but it's a little bit different than that amphetamine type stimulants or methamphetamine, like including that in there. It does not necessarily cause that dopamine flood. And so long term, it tends to be a little bit less effective when we're talking about treating an attention disorder or just how people are feeling, but be safer for someone long term in terms of brain health. So to explain a little bit also about some of the difference there about why they might recommend a methylphenidate formulation over an amphetamine type formulation, it's just because technically speaking, they are a little bit safer. But the most important thing if you're going to prescribe, if you're a prescriber and you're considering prescribing one of these, remember to always use the long-acting formulations. It is not a good idea to give someone a short-acting stimulant for someone with a stimulant use disorder. There have been a couple trials of that. They don't really work well. And again, it's similar to the concept of methadone with an opioid use disorder. You want something long-acting that's going to cover them throughout the day and not give them those peak highs that kind of reinforce the feeling of a substance use disorder of taking and stopping and taking and stopping. I think we've covered all of that. So just, I have a little slide on here about detoxes for GHB. I'm not going to read through that, but I just wanted to include that for reference. And I just wanted to talk about meth chill packs and then the research real quick before we wrap up. So this was a really interesting study. Like I said, one of the issues with people who use stimulants is that if they don't sleep for a while and they go on like a longer bender, they eventually will become paranoid and psychotic. And of course, then they'll end up using the emergency room or they can get into trouble with law enforcement or other things like that. So we really want to avoid that. So olanzapine is an antipsychotic. In this study, they basically gave people like a self-administered doses of antipsychotics as a way for people to self-treat either taking too much stimulant or staying up for too long, and therefore, in either case, getting these paranoid or psychotic, like psychiatric symptoms. And they found that it actually worked pretty decently well in terms of also even reducing hospitalization, which I think is great. It's unclear about if how well it works long term. These tend to be patients that are going to be very hard to follow long term. But I do think this is another really interesting intervention that's newer that can be considered. I'm kind of almost thinking about this as it's not quite the same as like Narcan for an opioid use disorder, but it's sort of similar concept of you take too much or you've done too much, and now you want to self-administer something to bring you back down. So hopefully you can sort of, avoid a emergency room visit or potential other negative consequences from untreated psychosis. I did put that little caveat there that it is unclear if it's actually a good idea to give someone an antipsychotic to use all the time who's actively using meth. There are some studies out there that suggest that because meth increases the dopamine and antipsychotics block dopamine, that giving someone an antipsychotic in active use because it blocks some of that dopamine might make them use more. So I wouldn't necessarily always think about like just giving them across the board antipsychotics, but that's also why this is sort of a one-time dose and not a continual thing for these people to take, because it's not necessarily good for them to take it all the time. EMS also, which is transmagnetic stimulation, has also shown some benefit. Definitely an emerging therapy. I would also put actually ketamine as a potential emerging therapy for this as well, for methamphetamine use disorder. So hopefully we'll see how that develops. Now, this last piece was just about future research. I want to open up for questions. All I actually want to I've mentioned most of this as we've gone throughout the talk. I just want to show these two summary slides. One of the biggest issue when it comes to studies about medications for stimulant use disorder or behavioral treatments is that most commonly the variable that they're studying is whether or not XYZ affects how many negative drug screens someone has. So it's actually not, in some ways, it's not surprising that contingency management, well, it's great that it's effective, but that one is really built around increasing the behavior of abstinence. You know, a disordered relationship with a substance isn't just about the use of it. So you can have a positive urine drug screen, but have like an okay relation with a substance. So what we really need more of is research that shows the effects of different treatments, behavioral interventions, medications on clinically relevant things like mental health, like outcomes like anxiety and depression, quality of life metrics, as well as and like drug use or health, I think are really important. HIV outcomes would be another really great way to do it. And there's actually some more slides here you can use for reference about some of the different ways you could do that. But that's also what I want to end on, is just sort of imparting that there's a need for more research on interventions for stimulant use disorder. But more than a need for more research, it's a need for research that's designed around relevant outcomes, not just around urine drug screens being negative. Because I think that one of the main reasons also why some of these medications were overlooked is that they didn't necessarily increase abstinence. But again, a negative urine drug screen doesn't tell us about how disordered someone's relationship with a substance is. It just gives us a very time-specific piece of data. So I'll stop there and I'll go to the reference, the resources slide. We can talk if you have through any questions you have.
All right, Yona, thank you so much. We have quite a few questions to get through, so I'll just jump right in. With the first question we have, could you explain the difference in items for stimulant and opioid kits that are in the vending machines?
Yeah, absolutely. So usually with like an opioid, you're like depending on what kind of like opioid they are injecting, there's going to be different supplies to basically like make I'm saying make the heroin. It's not really heroin anymore, but like heat it and cook it and all the other jazz. With meth, because meth is essentially like a salt, it just dissolves in water. And the way that most people sort of load those syringes is just very different than someone preparing a syringe of an opioid. And also because we knew that our patients are oftentimes using that in a sexualized context. We have just actually a little booklet on safer meth injection, so that's part of it too. Having like the mixture, there's like a little mixture of saline. I'm trying to remember all the things in the packet, but actually better than me describing from memory what's exactly in the packet, this video, which is on the resource slide, and I would recommend seeing it. Where is it? Oh, how to video on safer injection of stimulants. That goes through that really well. And yeah, I guess the big difference is that it does not have like the cooker supplies in the meth kit. It has some sexual health stuff in the meth kit. And it has like a little pamphlet on the differences for the meth kit. So those are the biggest differences. It's not necessarily like you could get by with an opioid packet if you were going to inject meth because you just need less things generally, but it's more about it being like kind of like specific to that community. So also they feel sort of seen and more likely to use that service.
Right, thank you. All right. What are your thoughts on a nutritionist seeing every client for nutritional support, such as Booster Insure, as these have street value, and we have clients ask for Insure in order to sell or trade for their substance of choice?
Yeah. That's a little bit of a difficult one, although I guess I'm not really concerned too much about diversion of ensure, in the sense that you're not like certainly the diversion itself isn't harming people. I think it really has to be client specific though. If the person really has significant like malnutrition and wasting, I would think that it like still should be given to that person because they also might use a portion of it and sell the other portion of it, and that could still benefit them. I think it's going to have to be a person by person basis. I don't think I can tell you like a uniform rule, but I usually err on the side, especially if it's something where the diversion isn't necessarily harming people. That like I would rather them maybe get the chance of having some better nutrition, which could sort of prolong or or improve their long-term health, versus just being worried about sort of the diversion piece of it. But that is interesting. I guess also I might consider protocols for trying to give them the ensure in a way that prevents that. Like maybe giving them smaller amounts over time or something like that, but that could also be somewhat difficult. So I think it's going to be setting dependent, and you're going to have to just sort of have like specific patient selection. But yeah, I could see how that could be difficult.
I heard that individual counseling is more effective than group counseling for STUD. Can you provide any insight or studies that support or don't support this statement?
I don't have any studies that I could give you off the top of my head. I think also different things work for different people. And I would say that actually, when we're talking about the discrete interventions like CBT, usually that is actually done in a one-to-one setting. Groups, a lot of times when we say groups for a substance use disorder, we're not actually like even necessarily like talking about a formal therapy group, like a CMA, like a Crystal Meth Anonymous, or like a 12-step program. Those are not like those are different than true therapy interventions. And so we just actually have more data about the one-to-one interventions, which are more effective. There's only a few kinds of like true therapy groups that are really like therapy, is what I would say, versus sort of like just like a kind of group, if you will. So I think that's where also some of that comes from is that like when we're talking about the discrete interventions, usually those are done sort of on a one-to-one model. But I think different things are going to work for different people. For some people, 12 step is amazing and it works great for them. For some people, having like a therapeutic group where you're just sort of talking like in a non like structured way about usage or other things like that, that can be helpful for some people. I don't like to think about one way as like the size fits all for everyone. I really think that some people may benefit from one-to-one, some people may benefit from the groups, and people should probably just try both until you find what works for that person. I wouldn't necessarily tell someone like, oh, this isn't going to work for you, so you should try one-to-one therapy because it's better. Because maybe it's a person where they really would actually would benefit from that support. So I wouldn't really necessarily talk to patients about it that way. Same way with the medications. Like I think contingency management is great and I want to promote it. But at the same time, I would not be like, these medications are not nearly as effective, and so we shouldn't bother with them. I think honestly, we don't have anything that's a silver bullet. So the more that you can offer people so they can find what works, the better.
Does concurrent GHB and cocaine use have a similar effect on prolonging the effects of cocaine and concurrent alcohol and cocaine use does?
There are so many concurrences. So let me just repeat it back to see if I understand. So does mixing cocaine with GHB have a similar effect to mixing cocaine with alcohol?
Correct.
They do. So GHB does work on those same receptors, and again does have some of those dopamine effects. So there would be sort of a lengthening effect. The thing I would worry more about though, or the interaction to remember with GHB, is really about the GHB and the alcohol, because those are the ones that are going to interact very strongly together and really put you at high risk of passing out. One of the reasons actually why GHB was scheduled in the first place is because of people mixing this with alcohol in like a party situation, like not like a rave or other kind of like sort of like setting, and large droves of them passing out because of that mixture. So I would say that's really the primary interaction to remember. I guess like it would lengthen the effect of that, but I wouldn't necessarily be like as worried about that as like a primary concern of an interaction. Also, I don't think telling people that that's like, well, I guess they could help them, the knowledge could help them moderate their substance use. But I think the more important thing for people to understand is the alcohol and GHB interaction.
Have you ever prescribed bupropion or mirtazapine for methamphetamine cessation? If so, have you seen any efficacy?
Yeah, so one of the clinical trials that was very promising was bupropion plus naltrexone, which is the long-acting injectable monthly version of naltrexone. I mean, I do this, this is what I love to do. Most of my job now that I'm remote is still just doing my like addiction psychiatry. And so I've definitely seen it be helpful for many people. I think mirtazapine's greatest use also is a come down med. People love to use benzodiazepines like Xanax or Valium or Ativan as come down meds. It's actually a horrible idea. Research has shown that using benzodiazepines in that context is associated with a higher risk of death and hospitalization. So I really advise people not to do that. And mirtazapine is a very safe come down med, or just a med to reestablish that sleep wake cycle. So for a lot of people, one of the problems that they have is that they no longer have a regular like sleep wake cycle where they're like awake during the day and sleeping through the night. And that causes a lot of problems for people, and it can just really make them feel unmoored. So I think it's really great for that piece of it. Also, if someone's on the thinner side, I think it's great because it does increase the appetite a bit, so it can hopefully help try and reverse that trend. I've definitely seen mirtazapine be very helpful for people, mostly in the come down med scenario, but some people have also continued to use it for the sleep wake thing. I've used the bupropion naltrexone. I basically used, I think, yeah, I've used all the different things that are on that slide for different people. But again, it's really not a one size fits all approach. It's going to be tailored to what the patient is concerned for and what their problems are. If their problems are is they want to feel awake during the day and they want to be able to go to sleep at night and have like a regular sort of timing because they got a job and now they're trying to keep with it, I might consider either bupropion plus like the mirtazapine at night to establish that, or if I don't think the bupropion is strong enough, maybe I'd use the long-acting oral stimulant. So that way they're awake and focused and feeling normal, like during the workday, and then able to go to sleep at night. If someone's coming to me and saying that they're getting really bad flashbacks to meth use and it's making them want to use again, I might use the topiramate, which is kind of like a mood stability drug that like can be helpful for people that get like the flashbacks and things like that. Really, it's about patient selection for any of these drugs, and telling them about what these different medications can offer them, and see like and sort of doing it that way. I don't think any of the medications for stimulant use disorder are as easy as like you have this disorder, so I just do this or throw this at you and see what happens. It's really about specifically being like, what is bothering you about like your stimulant use disorder or your stimulant use? Is it that you just generally want to help with cravings so that way you lose less? Is it that you want to feel more normal on the days that you're not using? Is it that you can't sleep? Is it that you're anxious and depressed and you're worried that's making it worse? What is it? And then selecting things based off of that.
Okay, we have a couple more questions, few more questions. As far as therapy goes, I know that CBT has been found to be effective as well as other short-term brief therapies. Do you have any thoughts or opinions on more of the humanistic model or the trainings that come from Dr. Gaber Mate, which persists that connection is the antithesis to addiction? I know these are hard to quantify, but I am very curious about your thoughts.
So the way I think about that is there's really great meta-analyses looking at like sort of like the linkage between the social determinants of health and a substance use disorder. In some of the other lectures I've done through NAHUD, I've had actually a lot of slides about that. And it is actually quite clear that we know that community is a really important protective factor for people from developing a disordered relationship with a substance. So I think that it's hard to quantify on like a micro level, like you just mentioned, about like the effect of community on a substance use disorder, and you can't prescribe community or like integration, reintegration. But we know that it works because it's protective. And there also are other models that kind of show about how community integration in general or reintegration is really important. So if you use another analogy, for example, to the carceral system, systems like I believe it's Finland's system, which like has a huge focus on reintegrating people after their time, and also treating them more humanely during their time that they are incarcerated. They usually have open prisons and other things like that. But they heavily focus on the reintegration because they know that community is really important. So I definitely think that some of those other models are really valuable. And I think that it's really important to also, if someone is looking to achieve abstinence, sure, achieving abstinence is the first step, but what do they do afterwards to maintain that? And one of the biggest things is about finding a satisfying life that does not include the substances. And so I think that that has to be thought about sort of like early and then often, and reintegration is a big part of that. But specifically in the sexualized drug use context, I see one of the big issues is that people will isolate themselves, and that's how they achieve the abstinence. But then it doesn't end up being sustainable because they haven't actually successfully reintegrated. And so that reintegration into community is really important. We're just about at
Right.
time, I think. I can answer a question or two more if you would like. Thank you all so much for
Okay.
coming. And sorry, the chat isn't very active. Usually, I like to try to read it as I'm going, but it's been so active. I don't think I could possibly read all this fast. But I'm also happy to take questions via email as well. If any of you want to send me an email, you can always do that. Yeah, I can peruse these submitted questions. So this has I think my email and LinkedIn, but you can also get your my email, I think, from the Nahu folks.
Now, I popped your email in the chat
Oh,
earlier.
great.
And also, a lot of what's going on in the chat is just a whole lot of praise. They
Well,
really
thank you
loved
as
your
well.
presentation. And if you have time for one more question, we have one here right at the top. Do you see risk reduction approach being able to use contingency management or only abstinence?
Yeah. So I've had this conversation. So I'm not a psychologist. I just try to listen to the ones that are. My understanding is that you can't it's in order for something to be the discrete intervention of contingency management, which has been specifically studied always as an abstinence-based protocol. If you're trying to make like a contingency management-esque program that's not abstinence-based, that's a new thing. It's like, so if you think of contingency management as Tylenol, and they've studied it as Tylenol, and you're now just trying to give Tylenol to more people, that's the Tylenol is a discrete intervention. If you keep on changing the things about the program, the contingency management program, eventually it's no longer the same intervention. That doesn't mean that it's not going to work or it's not worthwhile. It just means that it's not contingency management, if that makes sense. So I am not categorically at all against, if you're talking about my personal opinion about incentive programs for harm reduction programs. And some of the work I've been doing in advocating for contingency management, what I would actually like to see is contingency management offered in tandem with a low threshold incentive program just to get people into care. Like a program, for example, that maybe incentivizes behavioral health visits or other sort of general. I think in general, one of the current place I work for, which is the Medicaid managed care organization, we incentivize health outcomes like HIV viral load suppression and other things like that. I think incentive programs are great and they have a lot of utility. It's just that if you change contingency management too much, you just can't call it contingency management anymore because it's a discrete thing.
Okay, and to be mindful of your time, we do have a couple more, but I'll ask one more if that's okay.
Sure.
Okay. Can you speak to to the fallacious notion of the new meth that has been sensationalized? The idea that beginning 15 or so years ago, the methamphetamine largely available in the United States almost completely shifted to PCP cook precursor, and the chemical formulation of this version of methamphetamine is supposedly much more harmful for mental health, causes much more psychosis, and has all sorts of other pernicious effects. Can you speak to the fallacious notions of the new meth that has been sensationalized?
So there's two things I think I would say to that. The first is that, like I said, I think it's great to get in touch with your local forensics labs, and that's the easiest. I'm a big believer that data is which is the source of truth, is the best thing that we can sort of bring forward to our patients. And that way, that if you have your regional data, that's an easy way of being able to have those very data-driven conversations with patients about being like, this is what's out there. Now, when it comes to PCP, it is true that PCP is a very bad substance. And for me, it's actually one of it's not easy to treat either. It's one of the most untreatable, and it can cause a lot of permanent sort of psychological or damage. So I do think that part of what you were saying there, I think there is the truth that PCP is a very harmful substance. PCP is more of like a psychedelic. And so I don't necessarily see often people who are taking PCP and thinking that it's meth, just because it is so different. I have definitely seen before and encourage people to test their ketamine for PCP because since ketamine is also kind of in that psychedelic space, sometimes it is adulterated with PCP. And I do agree with the notion that PCP is a very harmful substance, but I have not seen it that it's like that was a replacement for meth. Again, just very different. But I think that the best way forward or out of that problem, if you have community people who think that the meth is actually PCP, is just to go to your forensic data. The last thing I'll say is that of all the drugs, meth tends to be meth a lot more than most other drugs are the drug that they say they are, just because it is like somewhat reasonably easily produced. I mean, if you were actually really motivated, I shouldn't probably say this, you could go on Reddit right now and with like ingredients that you can acquire relatively easily, you could make a small batch of meth at home. And that's why also, and there's meth labs within the country, so it doesn't necessarily have to be imported like some of the other drugs. So it tends to be that like meth, certainly all substances get adulterated and things like that, but it's just there isn't as much of a sort of like need to adulterate meth as there is other substances. Because you're not dealing with a like highly like difficult like supply chain like there is for cocaine, for example. It's actually one of the problems too, is that my understanding is that it's actually far easier. I think it's easier to manufacture fentanyl than other things than some of those newer synthetic like ways to synthetically manufacture it. And that is also part of the reason why it's proliferated is the manufacturing always plays in. I'm not an expert on that, so I think you could do a deep dive about drug manufacturing and sort of like how that works. But I do know that it definitely is something that sort of influences what drugs become prevalent and what like and whether how adulterated they are. But thank you
Okay.
so much. And yeah, my email's in the chat if you'd like to follow up. But otherwise, take care and have a great weekend, everyone.
Well, Yona, I just want to point out that the QR code is not, it's a site that can't be reached.
Oh, in that case,
Um,
forget the QR code, just go with email.
well, thank you so much for your time. We really appreciate you being here today. Um, yeah, so we can chat offline. Everyone, have a great rest of your day and have a wonderful weekend.
Thanks, y'all.